consultant hematologist. He's from the Uganda Cancer Institute, where he is head of the Division of Medical Oncology and Hematology, and he is the immediate past board chair of the Palliative Care Association of Uganda. Dr. Dungu has been associated with the work of palliative care for long, and he has worked within this field as one of the pioneer doctors of palliative care in our country. He is keen on making sure that access to medicine for people with life-limiting illnesses is improved. He has been at the forefront of the integration of palliative care, even within the Uganda Cancer Institute. And he is one of the very key friends of the Palliative Care Association, but also the palliative care concept, not only in Uganda, but regionally in Africa and also globally. And so I want to request Dr. Dungu to please take on the floor and make your presentation. He is standing in for Dr. Jackson Orem of Uganda Cancer Institute, who has requested him to make the presentation. Thank you so much.
Thank you, Mark. Good afternoon, ladies and gentlemen, from wherever you are. So let me see if I can. Are you able to see my slides?
Yes, we can, very well.
So once again, thank you so much, Mark, and the entire team for the opportunity. I don't know how much time I have, but I'll take a very short time to really talk about this component of, the comprehensive cancer care, looking at palliative care integration into the hospital. As rightly said, I'm from the Uganda Cancer Institute. Maybe to remind each one of us is that the World Health Assembly recognizes that palliative care is an approach that improves the quality of life of patients and their families who are facing the problems associated with life-threatening illnesses such as cancer through the prevention and relief of suffering, and by early identification and treatment of pain and other symptoms, be it physical, psychosocial, or spiritual. This definition, we've said it over and over again to emphasize the importance of the holistic approach to patient care. We all understand and we recognize the fact that palliative care improves the quality of life and human dignity, being an effective person-centered health service that values patients' need to receive adequate, personally and culturally sensitive information on their health status and their central role in making decisions about the treatment they're being given. We should also remember that there's an urgent need to include palliative care across the continuum of care, especially at the primary care level, as inadequate integration of palliative care into health and social care systems is a major contributing factor to the lack of equitable access to such care. So we need to make sure that at all levels, we are able to integrate palliative care. In this publication that came out in March 2019, again, they are looking at the timing of palliative care. When should we call for a palliative care expert to see our patients? So in the abstract says that palliative care, unlike hospice, can be utilized concurrently with disease-modifying or curative therapies. Some of the benefits of palliative care include improved quality of life, less end-of-life treatment, and decreased medical costs. So we need to keep in mind all those, that if we integrate palliative care early, then we are able to probably reduce on the costs associated with care that sometimes may not be even necessary. Okay. Again, to remind you that among the resolutions made in the 67th World Health Assembly, the one that we know is the resolution on palliative care up to now, the Assembly considered that the avoidable suffering is perpetuated by the lack of knowledge of palliative care and highlighting the need for continuing education and adequate training of both hospital and community-based healthcare providers and others, and urged member states to aim to include palliative care as an integral component of the ongoing education and training offered to care providers in accordance with their roles and responsibilities, according to a number of principles such as basic training and continuing education on palliative care being integrated as a routine element of all undergraduate medical and nursing professional education and as part of in-service training of healthcare workers and care providers. The training should also be, at an intermediate level, offered to all healthcare workers who routinely work with patients with life-threatening illnesses such as cancer, including those working in oncology. When you see this image of Makerere University Ivory Towers, just to bring out the idea that people should be trained at the level of such excellency, high-level training, such as specialist palliative care training at tertiary level institutions to prepare healthcare professionals who will manage integrated care for patients with more than routine symptom management. Because much as we talk of palliative care being available at all levels, time comes when you need people who are highly trained and specialized in this kind of care that, when, for example, I fail to do what I need to do, there's someone else I can run to help me integrate and provide palliative care. So coming back to the Uganda Cancer Institute and our commitment to integrating palliative care as part of comprehensive cancer care, I must say that, when palliative care started in Uganda way back in 1993, I think it was in Zambia Hospital and then Mulago Hospital. And Uganda Cancer Institute by then was part of Mulago Hospital under the Department of Medicine. So it was a small unit in Mulago Hospital. Uganda Cancer Institute recognizes the existence of diverse, cost-effective, and efficient palliative care models. And one of these is a hospital-based model that we are currently implementing. And also acknowledges that palliative care uses an interdisciplinary approach to address the need of patients and their families. And Uganda Cancer Institute has built strong networks between professional palliative care providers such as Hospice Africa Uganda, Kawempe Home Care, the Palliative Care Association of Uganda, and so many other providers, because it is based on these strong networks that we can deliver quality palliative care. So we highly recognize them and include them in our networks. UCI recognizes the need for adequate funding mechanisms for palliative care programs, including for medicines and for medical products. And that's why in our budgets, we include budgeting for what we need to use in palliative care, including the chemotherapy that we give, because many times the treatment is palliative to help alleviate suffering among our patients. And we have adequate access to all these medicines. Almost 90% of the basic medicines that we need in oncology, we have at the Cancer Institute. Again, to emphasize our commitment to palliative care, we have a Uganda Cancer Institute structure, which was approved, I think, in 2023, with a division of rehabilitative and palliative care. And in this division, the fact that it's a division, it should have a senior consultant in palliative care, should have a consultant in palliative care, should have medical officer special grade in palliative care, and medical officers, of course, as well as nurses who are under a division of nursing. So when you see this, it's a serious commitment of integrating palliative care into the routine care of patients at the Uganda Cancer Institute. Again, Uganda Cancer Institute, in accordance with the World Health Assembly, affirms that access to palliative care and to essential medicines, including opioids and analgesics, such as morphine, contributes to the realization of the right to the enjoyment of the highest attainable standard of health and well-being. This is an affirmation from the World Health Assembly, and UCI already has been doing this. UCI, as many of you might know, is the biggest consumer of oral morphine in Uganda. Here, the picture you see is actually morphine in our pharmacy. We have different concentrations, the green one and the red one, to make sure that our patients at any time are free from severe pain. Again, I talked about the interdisciplinary team. When you look at this nurse is wearing a uniform that has palliative care, because this is a palliative care nurse, and working together with the other doctors who are doing a ward round. So we are all working together at the same time, because palliative care has been fully integrated into our routine care. Even when you see, some people think palliative care is only end-of-life care, but some interventions such as blood transfusion have been found to improve quality of life of some people when it is needed at that time. So again, our team can integrate all that. And we don't forget about our survivors, because we know that also survivors need to be taken care of, okay? You look at palliative care as an approach that begins with a comprehensive assessment of domains of an individual's life, including the physical, psychosocial, social and spiritual arenas. Communication and decision-making for difficult issues should include, responding to emotions, planning ahead, and then the key palliative approach to symptom management includes addressing the associated symptoms and psychosocial concerns. And all these we consider, as has been noted in this publication. At the Uganda Cancer Institute, we encourage all patients to achieve and maintain a healthy lifestyle. The habits that have been associated with improved overall health and quality of life. For some cancers, a healthy lifestyle has been associated with a reduced risk of recurrence and death. And also, we talk about dietary supplements. We don't routinely recommend them for purposes of cancer control. So we don't, what I'm trying to say here is we treat our patients, follow them, and now we are having a survivors clinic where people come in for surveillance to check for other conditions. And we encourage survivors to set incremental goals for diet, physical activity, and weight management without being misled by people who come in with various ideas. I can also urge all of you to make sure that we keep active. Many people find that staying active can actually help their self-image. Some things they can try include walking around, swimming, playing a sport, even sitting on a carpet and do yoga, etc., as part of comprehensive cancer care for our patients, even those who have survived, or those who are still undergoing treatment. This is a general message that to achieve palliative care integration, governments should adopt adequate policies and norms that include palliative care in health laws, national health programs, and national health budgets. Ensure that access to medicine for pain relief and palliative care, including pediatric formulations, is available. And to ensure that palliative care is part of all health services, from community health-based programs to hospitals, and to have it fully integrated. And also to engage the universities and academia, as well as other teaching institutions, to include palliative care as called for by the World Health Assembly in their 67th sitting. And in conclusion, How best to integrate palliative care into cancer care is an area of active investigation and interest, but there are strategies that are in place to help integration, such as creating reproducible outcomes and flexible structures, starting small and learning quickly, but at least we start. So for all other institutions, let's start small. As you say, it's starting small, but we are willing to do so and continue. And to leverage primary and specialist palliative care teams, and also making sure that we measure all the time. Because when you don't have measurements, we cannot convince people that actually we are doing this. So individual institutions need to define the optimal level of integration that would have the greatest acceptance and impact at the local level and monitor the clinical outcomes. I want to thank you for this time. Thank you, ma'am.
Thank you so much, Dr. Dungu from the Uganda Cancer Institute, and thank you for keeping your time. It is good to see that Uganda Cancer Institute is integrating palliative care within the comprehensive care that the institution is offering. We are grateful for the partnership that still happens with the rest of the organizations that work directly with UCI. For all our friends that joined after we had introduced, we requested that you type your names and where you are joining in from in the chat. I'm grateful that we have some people all the way outside of Uganda. I saw Randy Diamond from New York. Thank you so much for joining. And all the leaders on the call, Dr. Jane White, thank you. The Center for Hospice Care team that is online. And it's good to see all of you, including our partner associations. In Malawi, I saw some people from KEPCA who really want to learn about what Uganda is doing. And for all the questions, please type them in the chat, in the Q&A. I'm going to request Dr. Rosemary Kusaba Byanyima to come. She is the Executive Director of Mulago National Referral Hospital. Previously, of course, she was Deputy Executive Director. She's a seasoned consultant radiologist that we all know. One of the things that we remember you so much, Dr. Byanyima, about is your zeal and fight during the COVID-19 pandemic. And perhaps the entire country and all of us who relate with that will always know and remember your name and how much you did to make sure that our country was safe, and for all the people that were there in Mulago that worked with you. Still, the same question is put to you. We would like to hear from you how the National Referral Hospital is taking steps on a commitment to integrate palliative care to be part of the comprehensive care that you offer. Dr. Byanyima.
Thank you very much, our moderator. It's indeed a pleasure that I'm given an opportunity to speak on this webinar, and we don't take it for granted as Mulago National Referral Hospital. I'm not going to share a slide that request that you listen to my speech. The topic which you gave me, that is about the commitment of Mulago National Referral Hospital in strengthening palliative care. When I read the topic, I said, well, is there any doubt that Mulago National Referral Hospital is not committed to palliative care? But of course, the answer is no. It's an honor to talk about this topic on this national commemoration of the World Hospice and Palliative Care Day. This is a topic that touches lives of many individuals, families, and of course, communities. And I'm sure all of us have had that experience. At Mulago National Referral Hospital, we recognize that health extends beyond treatment of patients for cure. And this we see in a daily. Of course, healthcare encompasses holistic well-being of an individual and families. And palliative care is an essential component of comprehensive hospital-based care. We have to provide not only for alleviating somatic symptoms, but also emotional and psychological plus spiritual needs. And that's why as a hospital, we have the 3 prayer places for the Catholics, for the Protestant, and the Muslim. Of course, those are the leading mainstream faiths in the country. We do also allow the other faiths to come in the hospital with clearance from administration, because of course we do not want the wards to be crowded. So we know that the spiritual bit is also part of the care that we need to give, especially for those with chronic and long illnesses, especially those who are terminally ill. So palliative care, as already said, is about improving quality of life, and it is vital for patients facing chronic and terminal illnesses. And it's good to alleviate suffering and provide comfort, even if someone knows that you are heading to the end of your life. And it's a fundamental human right. We all know that we should really put these people who are suffering in a state of comfort, so that and if they are to rest, they rest with the dignity and respect. So in Uganda, the need of palliative care, especially in Mulago, is very high. You know, Mulago National Referral Hospital has 1,700 bed capacity. So you know what that means in terms of the percentage of patients who come who are terminally ill. And being a referral hospital, we get patients who have chronic illnesses and terminally ill when sometimes they are referred a little too late, even conditions which would have been alleviated. So our range of patients we see a big number of patients with cancers. Even when they go to the Cancer Institute and they are given treatment and they go back home, when they feel unwell, they show up in our emergency, and you cannot tell them now, go back to Cancer Institute. And we know that is our sister institution. So the other patients we see are patients with the chronic renal diseases. Those, you know, there are quite many and they are on the rise. Chronic obstructive airway disease, I think with time, of course, we need to work towards having ready access to some of oxygen concentrators which can be carried as backpacks so that these patients can be ambulate. But those are some of the real ill patients that we see. And the list can be so long. So it is a challenge to the hospital that the numbers are big. But as a hospital, Mulago National Referral Hospital is committed to taking care of these patients and in a comprehensive way. Manage their pain, manage their emotions, also talk to the families, because eventually, even if you are to discharge these patients home, the family should know what they are handling. So we do a lot of counseling for them. So at Mulago National Referral Hospital, we take deliberate steps to provide palliative care services. One, as one of the training sites for many institutions, including Makerere, we work with Makerere College of Health Sciences to provide training for palliative care staff through formal trainings, and some of which we do in collaboration with the international experts, continuing medical education within the institution, as well as workshops. Those are some of the things we do for training of professionals who do palliative care. But we've also integrated palliative care into our service, more so by creating a division of palliative care and in our new structure, which if we staff is optimally to have at least 20 permanent staff. And this will include from assistant nursing officers to the level of senior consultant. We have put this division under internal medicine and created an office so that anyone who needs their service has an address where they can go and consult them and leave a consultation form so that this team can visit the different wards. So to me, that is a big commitment and a big step forward. We are doing a bit of community engagement, but of course, not to a big extent. We work through our social work division also within the hospital, and in consultation with the psychiatry department is the one which has psychologists who can do also a bit of psychosocial counseling. So the palliative care team, together with the social workers and the psychologists, also work together to support these patients and their families. We are privileged as Mulago to sit on different boards and also participate in policy making. So whenever we have an opportunity, we do advocate for palliative care. This is not without challenges, but we look at challenges as opportunities. We have limited resources in terms of staff. So sometimes we make use of the students who are rotating also to bridge the gap. And we hope that soon when we are able to recruit, we shall recruit more so that the division of palliative care is well staffed. And to us, having been given a structure was the first step forward. There is limited public awareness, and I'm glad we are here talking about it. And I see over 84 people online, and I believe maybe some people are watching too of them. And I think given an opportunity, we always talk about this. When we have like medical camps, the open days, which we have for Mulago, one we had for internal medicine, and palliative care had a stall and was able to talk to as many as they could. We work with other institutions and government bodies. Of course, Ministry of Health, Cancer Institute really is our sister institution. And the Palliative Care Association, they know how we work with them. And other NGOs that help us also to reach out to the communities. And most especially to try and reduce on that stigma. We get sometimes patients who are terminally ill being abandoned in the hospital because the communities cannot afford or they do not know. But as soon as the patient passes on, the same contacts you are calling and they're saying they're coming and they don't show up, they, you know, surprisingly, they come to pick the body. So that stigma that the communities attach, or lack of maybe resources, or lack of counseling about caring for terminally ill. I think we need to do more about that. So I want to appeal to all those who are listening and all other stakeholders out there to include palliative care, just like Mulago National Referral Hospital, even at lower level, into their activities. Whenever we have an opportunity to advocate for palliative care, and also to raise awareness in the communities that when as institutions we are caring for a terminally ill, we need to work with the families and the communities where these people come from. Lastly, I want to reaffirm that Mulago National Referral Hospital is committed to strengthening palliative care in the hospital, to advocate for policy strengthening for palliative care. I thank you.
Thank you. Thank you so much, Dr. Byanyima. And you've made a very strong statement at the point of discharging the patient to go back home, that the family should know what they are handling when they go back. Thank you so much for making that statement and for all the commitments that you have said. I can tell you that all the members of the Palliative Care Association of Uganda Online will really support the effort, especially on that point of informing people when they are going back home. We have developed a palliative care directory that has all the palliative care providers that allowed us to publish their names and their telephone contacts. And that's downloadable from our website. We pray that all clinical people within Mulago, all specialists, as they discharge their patients, they can call the palliative care provider nearer where the patient is going home, and they can interact. That even where it is possible, they can contact us and we can support that effort. We are grateful for the partnership, and we thank you for creating time for this webinar. We now want to hear from Dr. Andrew Sechtoreko. Dr. Andrew, you have been CEO and an amazing CEO. You recently were published among the top 100 CEOs admired in Uganda and of course in Africa. You are not new to this field. You are one of those pioneer doctors into this work of palliative care, and you've worked at Lubaga. Dr. Andrew is now the CEO of St. Francis Hospital in Zambia. Please take the floor, and you have 20 minutes.
Thank you very much, moderator, Mark. And I just want to confirm that you can hear me loud and clear, and my slide presentation is visible.
We hear you very well, loud and clear. For people who are watching, it would be good that you also keep your video on, if it's okay, as you present.
All right. I'm putting on my video as well.
Good.
All right. So good afternoon, everybody. A great pleasure for me to present today, this afternoon, on the commemoration of the Palliative Care Association of Uganda. It's 25 years. And as already introduced, I'm a family physician as well. And I also practice geriatrics as an extension of family medicine. And I want to talk about strengthening palliative care within hospital-based care in Uganda, but we're giving the commitment as St. Francis Hospital in Zambia. And as a way of giving context to palliative care, as already my predecessors, Dr. Byanyima and Dr. Dung, have presented, number one is that palliative care focuses on improving quality of life of patients with serious illness. And when we come to hospital, in the past, we used to think palliative care was limited to cancer, but now we've expanded that definition to include any serious illness. So who with a serious illness does not want to have a better quality of life? And then secondly is it gives a holistic approach to patient care. And most of us that deal with patients appreciate that a holistic approach actually improves outcome of care for patients. Overall, it aims at relieving symptoms, providing comfort, as talked about by both Dr. Byanyima and Dr. Dungu, support to patients and their families, And many times we're not trying to cure an illness. And this is a point of contention, especially in hospitals, that in hospital medicine and hospitalists, most of us were conditioned to try and cure illness. And when there is no cure in sight, the tendency is abandonment by many times the health workers, sorry to say, but also by the families. So essentially, it's about helping people feel better physically and emotionally during challenging times. And this everybody would love to have for their patients. So as hospitalists, as hospital practitioners, palliative care becomes a relevant and important discipline for us to incorporate. And so what's the rationale for us in hospitals to consider the integration of primary care within the comprehensive services of the hospital? Number one, of course, the population with serious non-communicable diseases is growing, and that is presenting us with many challenges. To start with, things like diabetes coming with diabetic foot. And diabetic foot will benefit from the things that I've just talked about on the previous slide, improving quality of their life, having a holistic approach and controlling of symptoms with a diabetic. But we also have a rising population of the aged. And by age, we say people with conditions that are associated with, let's say, advanced age. As a practitioner of geriatrics, many of these people will benefit a lot from a holistic approach rather than a direct disease approach. And that's the mainstay of actually geriatrics, that make sure all conditions are handled within the same framework. Improvements of healthcare, now we have intensive care units that are taking care of people longer. People are surviving diseases we thought they wouldn't survive. And with this now, we're finding ourselves with more clients needing this holistic approach to their care. As a way of stimulating discussion on integration, I asked the question, which department would you place palliative care in your hospital? And I put a few departments there. Would it be in the emergency room? Would you put it under labor? Would you put it under physiotherapy, laboratory? Where are you putting palliative care? And this is a practical question because a number of times integration requires us to align the existing with the new. Is this the same for general hospitals as well as referral hospitals? Because in a general hospital, maybe the departments are not as well elaborate. In Zambia, palliative care for the last 6 years has been hosted by the Department of Internal Medicine. But where we are now growing, and we've grown more into more of a referral hospital, and it's becoming a department of its own. It will be housed moving forward in a department we shall call the Comprehensive Care and Support Department. It will sit there together with the Office of the Social Worker. We have a chaplain, that is pastoral care. We have a psychotherapist, counselors, as well as palliative care. What benefits have been noticed with integration? Number one is patient-related outcomes. And the other will be number two, which is system-related outcomes. So patient-related outcomes include mainly restoring hope. Most of us clinicians, when we work with patients in the hospital, one of the things you see fading very quickly is going to be their hope. And when the hope is restored, most of us realize that it's easier to manage clients or patients. By clients, I mean their families and everybody else. When there is hope, when they see something to live for. So it is certainly something that we found as a good outcome. The second is that patients appreciate care better. In other words, they see the big picture because palliative care will bring the principles of holistic care. And this quickly makes patients see the whole big picture. And then, of course, there's appropriate preparation for end of life. Many of us have appreciated if you've had a patient facing end of life and they're handed over to a palliative care team and given appropriate walkthrough of what this entails so that people approach end of life without fear, but with a certain degree of confidence and hope. Regarding system-related outcomes, again, as already highlighted by Dr. Dungu, earlier initiation of care is much better than bringing palliative care at the end, where it seems like things have failed. Now bring in palliative care. A number of people actually reject palliative care once it's introduced at the end. I have a friend, a colleague, a doctor whose mother was ailing seriously with cancer. And when we mentioned palliative care, it's like, I'm not taking my mother into that kind of, and he called it actually, sorry to say, rubbish. Says, it's like you've given up on my mother. So early initiation is good so that people see that, well, palliative care has been all the way part of their journey. We've seen improved communication between teams. The palliative care team is a team, as you saw the picture in Mulago, that will work together closely with other teams, the internal medicine teams, the surgical teams, the oncology teams. These teams have to work closely together, and the communication has to work well when palliative care is on board. And then the strengthening of staff capacity to provide palliative care. Remember, while they are specialists of palliative care should be provided at different levels by most of our staff. At least every unit should develop to provide some degree and form of palliative care, or some form of palliative care being given with teams on the units. Just a brief overview of the current status of things in Uganda. We already know now that government hospitals provide 85% of palliative care services. I think mostly because government is providing services free of charge to the public. But does this immediately exclude the private sector? So we can see 77 private providers, which might constitute the other 15%, offering palliative care. That leaves us with a huge unmet need in some parts of the country, extending to about 90%. It means that a number of people who would benefit from services of palliative care within our hospitals are actually not accessing it. And why is that? Number one, there's lots of misconception and stigma, just like I talked about this doctor who felt maybe palliative care is for abandoned people. Palliative care may be for cancer patients. Palliative care is about failed cases. Next is limited resources and training of staff. So a number of people have not dedicated resources to actually ensure that we expand the reach of palliative care within our very staff in the hospitals. And then the fragmentation of services. This is that, when palliative care sits in one department, you find that that's the only department that utilizes the services. I mean, in Zambia, it sits under oncology, not reporting through oncology, but the actual physical space is provided within the cancer center. Thankfully, it's not only cancer that is consuming these services. Our teams will actually go into the wards and provide care. But in many places, when there's fragmentation, the reach will be reduced. So in Zambia Hospital and palliative care, Zambia Hospital has been around for 121 years. And we run with a mission of providing quality health care, education and research, especially to underserved populations. We were the home to the first palliative care practitioners in Uganda. That's Dr. Anne Merriman and Sister Rose Chiwanuka. These later went on to found Hospice Africa Uganda in 1993 when they left in Zambia Hospital. And then Zambia eventually opened a palliative care unit in the year 2018, which is about 6 years ago. That's after we recruited a palliative care practitioner. So right now we're running the unit with 5 staff. These are, 2 of them are trained. In other words, they're qualified palliative care practitioners, while the other 3 have been trained within the hospital. And the services this team offers is pain management, mostly with the administration of morphine, but also with some techniques that will support pain care. That is both to walk-in patients and admitted patients. On the right, you can see Sister Josephine, who is seated here with me in the room, but she's at our palliative care unit. She's the champion of palliative care in Zambia Hospital, and she's the practitioner that has been with us since the unit started. They do cancer care, cancer wound care. This I've had a personal experience myself with one of our patients who had cancer of the breast that eventually opened a very large wound on the chest. The wound was smelling. This was one thing that would have caused despair and failure for many people to gain any hope. But with the palliative care team here, this patient was in the private ward. The team visited her regularly and cleaned the wound. The wound did not smell anymore. And this helped all people, that were around her to tolerate or to stay with her even better and give other support. They support documentation of advanced directives. This is something that is still quite foreign to us in Uganda and in Africa. When people talk about advanced directives and wills, there's a tendency for people to think like you've given up on us. So the team does help family members to accept that decisions made in advance when patients are still clear-minded and lucid does help a lot the clinical team in delivering of healthcare. As we said, there's been a heavy development of healthcare in Uganda. Now we have intensive care units, but with intensive care units, there are people that stay on life support, and how long is this going to be? So we need to talk about things like do not resuscitate or stopping of care when we feel that it's not going to add any quality of life anymore. We have end of life support already talked about. We have bereavement management. This is people who have lost loved ones will find a lot of help and solace when health workers come to their aid. We do staff training, that's the palliative care team, train other staff in the skills and principles of palliative care. And community outreaches. In community outreaches, we find, for example, our local leaders. We recently gathered our local council leaders and talked to them about these principles. And we talked about care, cancer care, but also we brought a palliative care team to speak to them. And then home visits, which is one of our challenging areas. I must say that our team then goes down to the home visits. And many times when they're out in the homes, people expect a lot more than we bring. If we carry morphine and a few medication, some people we will find in dire situations, they've not had breakfast that day and you're bringing medication. I wanted to give what I call non-cancer consultations because in the hospital now, we are spreading beyond cancer care and we have sickle cell disease. This is actual data from our clinic. It's not all, but these are the top 10, you could say. We have patients with sickle cell disease, a number of patients with, we had a patient with elephantiasis, a painful one. We had a patient with cryptococcal meningitis, some patients, disc prolapse, rheumatoid arthritis, chronic wounds as already discussed. Fistula, depression, the team also is involved in providing counseling, and then burns care as well. All of these are care that is non-cancer related. And so we want to see more diseases that are non-cancer related involved. What have been the strategies for successful integration? Number one is leadership commitment. And here I credit my predecessor, Dr. Dumba, who ensured that palliative care was given a home within Zambia Hospital. Then there was establishment of a palliative care team. The team must exist. This team is not the only deliverer of care, but they are the coordinators, they are the core, they are the visible face of palliative care. Education and training for healthcare providers, as already talked about, and then raising awareness among us patients. Some of the consumers are going to be patients themselves. They will come directly. We have a number of walk-in patients who come and seek the services directly. Well, some of them may be coming from other centers, but some may be referred by other clients. Collaborative models, this we've already talked about, interdisciplinary teams. So the palliative care team being invited to attend maybe during a ward round of a patient that we feel may benefit from palliative care, and also the communication between specialties. And finally, the inclusion of palliative care in our accreditation program. On the right of our screen is COSASA, which is the Council of Health Services Accreditation of Southern Africa. And what is COSASA is a standard that we're following to accredit all services across the hospital. And in that standard, service element number 23, as shown on the screen, is palliative care, which has a set of standards that we must develop, and maintain to keep a good functional department. As a result of that, our team has developed a number of standard operating procedures. I've put some on the screen there, and those procedures and documents that are making sure that the care we provide is actually standardized and can be replicable anytime. I would like to conclude with our commitment. It's that we are working not without challenges, but we commit to the following: to expand the reach of the services of primary care, palliative care. I would like to say that palliative care now occupies one room in the hospital, one size room, but we'd like to expand this, and we've applied to take a few more spaces within the hospital. Would like to train health workers. That's an ongoing task, to have more health workers trained in palliative care. We want to support, as a hospital, home visits. So these home visits, the patients don't pay for. I forgot to say that our clients pay a one-off fee of 10,000 shillings, for which they get all the services that they need from the palliative care team. And so that includes even home visits. So this means that we normally have to provide a vehicle that moves with our staff, and they will go to the homes to offer care. We would like to continue supporting the outreach program. This is targeting the community. These are people who will become either referrals, they will send us referrals, but also themselves. Like to generate research on the effectiveness of integration of palliative care within hospital-based services. We would like to support innovations in palliative care delivery, and this is that any new ways of providing palliative care is something we'd like to explore and support. Finally, to advocate for funding and resources. We have already talked to Rotary and Rotarians from the Rotary Club of Muyenga. We've had the Rotary Club of Kampala Maisha visit, and they give of their own funds. That's at a local level, but we'd like to advocate for funding, just like Dr. Dungu and Dr. Byanyima have said, that the government should give more support in this area so that it's not falling into the neglected areas. I wish to thank you for the opportunity once again to share our commitment as Nsambya Hospital on how we can integrate palliative care into the general health care of the hospital. Thank you very much.
Wow, thank you so much, Dr. Andrew, and for all the work that you do at Nsambya. We are grateful that Nsambya allowed palliative care to start there, and there is no doubt that's why you are able to say and do all you're doing, because after all, the seed was there. Dr. Barnabas Atwine, who heads the Pediatric Oncology Clinic in Mbarara, agrees with you entirely. I saw in the chat that the palliative care should be perhaps at the central department where this should be accessed. And of course, Dr. Dungu agrees with you as well. He's the immediate past board president of PICAO. And when we are developing our strategic plan, the board and him at the lead were keen on making sure that palliative care is for all. And that's why the vision of PICAO is palliative care for all in Uganda, because indeed, we know that also some health workers, as you have said, need more capacity, as you have elaborated. And I hope that within the leadership of the hospitals and facilities that are leading, we can continue to offer this capacity. I am going to go through the questions very quickly. We don't have many of them, but Dr. Byanyima, you had a question from Mr. Robert Senteza, who is in Kakumiro. He was asking why is it that palliative care division is at the national referral, yet it should be at the district, where perhaps there is more health facilities down there, and that it would be entrenched within the primary health care. But as before you answer, we know at PICAO that within the new structures, there have been positions for palliative care up to Health Center 3. And so perhaps government is taking that direction, but you will answer and maybe emphasize why it is at that level. We have many comments and few questions, but most of them are really appreciating what we are talking about. And before we close the webinar, I just want to alert I saw Dr. Lilika online and Dr. Anne Merriman. I'll just ask you to say something brief, especially since we are talking about hospital-based care. You will say something brief as we close. But I will open for Dr. Byanyima to strictly answer the question about why is it at the national level, not regional level, not district level, that we have the division.
Thank you very much. Mark, you've already answered the question in a way. Of course, I, as the speaker, was speaking on behalf of Mulago National Referral Hospital and what we have done in terms of palliative care. And the fact that we included it in our structure, and we are thankful that Public Service approved that structure. Now, what is remaining is to make sure that we populate it. We already have a few staff, but if we expand it to 20, and I've already mentioned our bed capacity being so high, and the patients who need palliative care being in many different wards. So having a liaison office where now the small team sits and having to go around to the different wards is quite challenging because there are few. You actually come to the office and they have gone to the different wards, and you think that they are not working, they're ineffective, and you can even claim that they didn't come to work. But that is how liaison offices work, and would want to see that even other health facilities, please, if you have any wage, prioritize palliative care. If you haven't had someone trained to do that, please make sure you have people who are trained and not just on job. They need to have the knowledge so that they can do the right work. And that would even reduce on unnecessary referrals. You refer patients who are terminally ill, they incur expenses to come, and then we do a bit of palliation and then cancel them and send them back home. I think it's a joint effort right across from the lower health care level up to the National Referral Hospital. And my colleague from Zambia rightly said, the private sector also has a very big role to play, and this should also go for the lower level centers. I sometimes have a feeling that some centers refer patients who are terminally ill because they do not want to be the ones to break the bad news and be the ones to bear the burden of counseling the patient, and moreover, providing terminal care for such patients. So let's all have people who are qualified to do the work so that we do not refer unnecessarily, especially from up country. You know what it means. Someone has never been to Kampala and is referred to Kampala for a chronic illness, terminal illness. Would wish that these people can get care nearer home, near to their families, and that would make life easy for all of us and even for the patient. I thank you.
Thank you so much, Dr. Byanyima. Dr. Dungu, will you please answer the question from Amon about the use of local herbs, drugs, herbs, and how effective are these in especially treatment of cancer? Because this is a question that keeps coming up, and the issue of herbalists, and that's a point that Amon wants you to emphasize.
I think I'll not take a lot of time on that because for sure, the challenge we have is that most of us in Uganda and many other African traditions, when you get a condition that is life-threatening, what comes to your mind first is that this could be witchcraft. Or the other fact that we have, especially among the elite, is that maybe herbal remedies are safer than chemotherapy because herbal remedies will not take off your hair, will not do this and that, they are natural. So people resort to that. Unfortunately, what we have observed is that the response is not there. And some of the herbal remedies are not genuinely herbal. Some of our friends in practice will put in other substances that will make someone feel better when actually we're not dealing with a truly herbal remedy. And by the time a patient comes back for treatment, they have advanced disease. So my take on this is that we should not encourage use of herbs, especially if we have confirmed the diagnosis and we know that there is an approved treatment for that. Many patients with cancer are treated. Many patients with cancer improve. Many patients with cancer get cured if treatment is started early and appropriately. I think that's all I have to say.
Thank you so much. We do not have many questions. We have a few minutes to close our webinar. I am going to give you an opportunity to close up for any parting shots. Most of it in the chat is really to thank you for being able to avail your time to speak at this webinar. And a lot of it is an appeal. Like Toko says, my appeal is that we need to think more about older persons and they need our support and they face stigma, which is true. And we recently commemorated the International Day of Older Persons, you remember, on the 1st of October. And key among the highlights of what was mentioned is that health workers need to make sure that they respect the older people. And the chairperson of their council made it a point from the beginning of the speech up to the end that geriatric care should be part and parcel of what we do. And last week, at the beginning, last week we met the Right Honorable Dr. Rugunda, whom we have invited to be at our event tomorrow and graciously accepted. And he made the same point saying we have more older people, more older persons in homes who need care, who need the touch by health workers. So it's an appeal to health workers. Now, Dr. Andrew, you spoke about the need for more capacity of health workers. And as we conclude, as I will go around for all panelists to give their parting shots and all their recommendations, I'm going to put back the question to you on what you think as a recommendation that we should take from this webinar and the message that you have for all health workers who are listening in and who are on the webinar, because they are the majority, and most of them as palliative care providers, on what they can do to make sure that the rest of their colleagues appreciate the concept, in addition to what you advise, that the approach should start early. But as we all know, the large percentage of the patients that present, for example, at Uganda Cancer Institute, always come sometimes when it is not early, the opposite of coming when it is early. So you'll give your concluding shots, but I request that you answer that question as well.
All right. Thank you very much, Mark, and thank you all people who have contributed to the discussion. I think for us, the entry point for most facilities, just like we train maybe orthopedic doctors or we send pediatric doctors to go train, it must now become clear that palliative care is one of those specialties that we can take. And I want to say that the training is not that prohibitive. So the training is also available. If I talked about 10 years ago or 20 years ago, we probably did not have enough facilities to take people for training. But today I understand, you know, right here in Makindye or Mildmay or Hoima or Mbarara, many places now in Uganda where you find a hospice outpost, we can have training. So I request that leaders of hospitals look out for these programs and they support. As I said, the cost I don't think is prohibitive for institutions. I think it is the awareness that these programs are available and that they will add a lot of value to the overall care and satisfaction of patients within our system. I didn't present this as a business case, but this is one area where it's worth to invest and your value for money will return because the satisfaction rates are likely to improve. I thank you.
Thank you so much, Dr. Andrew. And Dr. Dungu, your parting shots for this webinar.
Thank you so much, Mark, and thank you, panelists. It's very, very important that we integrate palliative care into hospitals, but we also need to understand, as the World Health Assembly also recognizes, that we need to think about cost-effective models that we can use to make sure that palliative care reaches to all those in need, including those in the community. So my appeal is that hospitals should integrate palliative care into routine care, but also have strong networks that are going to help us to decongest the hospitals. Because a person who has cancer and desires to go home, they need care when they are at home. So I want to emphasize the importance of support to home-based care providers, because they're the ones that provide, the best care to a person, especially those at the end of life. So it becomes continuity of care from hospital to the home and otherwise. So home-based care is very, very important, and we need to integrate it. Thank you very much.
Thank you so much. Before I request Dr. Byanyima to conclude, I would like to know if Dr. Anne Merriman is online, and you can really mention or speak to the question from Toko about the older persons and the care for older persons. Dr. Anne Merriman, if you can make a comment quickly about palliative care for older persons, that would be so good. And then we'll ask Dr. Byanyima to give her concluding remarks and close the webinar. Dr. Anne? Okay, we seem not to have Dr. Anne Merriman. I thank you so much. And in the absence of Dr. Anne, would Rose make a comment for older persons? I know you even have an event tomorrow.
Yes, sorry, I was muted, sorry.
Oh,
I had
please go ahead.
Yeah, okay. Yeah, I'm so glad that you have the senior people in the hospitals to come and talk about this, but these are the people that we rarely see when our teams go in. And the people that our teams that go in are very worried sometimes at what they see, because the nurses on the wards do not appreciate palliative care. They often don't take any notice of. We are mainly in with the children, and sometimes there's a child crying in the ward, and the ordinary nurses have taken no notice of it. And this is very sad, because the nurses themselves in the ward need not only to know about palliative care, but need to respect the palliative care teams. And then sometimes doctors come in and say, oh, nurses shouldn't write in the case sheet because a palliative care nurse is written in the case sheet. But she's changed the treatment, and she needs to write in the case sheet, or it won't be carried through. But they don't recognize palliative care as a specialty. And the nurses actually are better than doctors at palliative care. Wherever we go, they are better than the doctors, because nurses are basically trained to communicate with the patient. Yeah. So sorry. So doctors can need to respect that these nurses are trained to diagnose in the community. They are trained to manage them in the community, and actually, once the patient goes home, it's important that they are looked after at home all the way through. And the Palliative Care Association has got palliative care in so many of the districts now that it's very few that won't be able to contact palliative care in the district to continue their care when they go home, but they need a referral from the hospital. Yes, we really need everybody at the hospital not only to see it, but to respect it. They're not respected because it's a nurse, but nurses are very good, and they have master's degrees in palliative care, many of them, and many of ours do. But now, you talk about training. We now have so many degrees that can be got through the institute at Hospice Africa. There's the initial one, which allows you to train morphine, which is a diploma. Then you have the bachelor's degree, which is 3 years. And then you have the master's degree, depending on what you've got before, is 1 year or 2 years. And these are very, very important. And we were delighted this year to have 2 people from the Ministry of Health on the master's course. And you see, doctors can actually come straight into the master's course, and they will get the basics as well as the advanced management of patients. So we do ask you to be aware of these, and we would ask the government people to please help to support them financially, because when these people are on low salaries, I think doctors can pay for themselves, but nurses, most nurses are on quite low salaries, have difficulty paying for it. And sadly, we can't take them on if they can't pay. So that's very sad. I wish to talk to the people who are here from the other countries that we have visited through international programs. Many of those start in hospitals. Why? Because they don't have the money to start a palliative, to start something out in the community. They don't have money to pay for that. So they start in the hospital. But in the hospital, very often, because they're in hospital workers, the chief executive, who doesn't understand palliative care, will actually move them from where they're working in palliative care into the theatre or into maternity, where they won't be particularly doing palliative care. And they become de-skilled. And I'm delighted to hear that Josephine is doing so well in Zambia Hospital. I was really upset about her because she was in the theatre for many years before you actually took her on as a palliative care leader. She's very good, and we were so sad to lose her during the time that we had to let her go. Okay, so we want to thank you all very much. Malago, we started your palliative care in 1994. We were teaching in the medical school then, and we passed it over in 2007 to others. And, so it came out of our hands altogether. But it is very important that we're teaching African palliative care. This is Africa, and Africa has African solutions for African problems. They're very good at that, and we find that using African solutions is very helpful in the community. So anyway, thank you all very much for your talks today, and I hope to see some of you in the wards, or at least to hear that some of you are in the wards. I don't get into the wards anymore. I don't get anywhere, but I am a geriatrician. I taught in 2 universities in UK on geriatric medicine. I was recognized in UK as a geriatric specialist, not as a geriatric, but as a specialist in elderly care. So, I had that, but that was in the 70s and 80s. And now I will be 90 next year. And so I am a geriatrician. So now I've seen life from both sides now, both as teaching and now as receiving all the problems in old age. So I want to thank you all very much for this, and to see that things are progressing in the hospitals is really wonderful. And please keep in touch with our nurses and recognize them as specialists in palliative care. Thank you so much.
Thank you so much, Dr. Anne Merriman. It's always good to have you on the call, and I really had to call you out to say something, having been the founder here of Hospice Africa Uganda. Dr. Byanyima, I will be concluding. We really would like you to also make a mention on what you see as the need for care for older persons, even beyond palliative care, really long-term care, and what your really comment is about that. Dr. Byanyima, as we close.
Thank you. And thank you, Anne-Marie Mann, for those remarks. And I'm glad to inform you that we still carry on with supporting palliative care training. And thanks to you for initiating that. I also wish to inform Anne-Marie Mann that at Mulago National Referral Hospital, we allow our nurses to write in the case notes. That makes the care jointed, so that the notes from the nurse are not separate from those from the doctor, because we are caring for the same patient.
Thank you.
Yes, as my closing remarks also, I think I want to call upon everybody to increase on advocacy for palliative care, because the need is ever rising. We need to advocate for resources in terms of human resource. We need to train all the academics It's been said very clearly that the nurses will be at the forefront. But of course, they'll need the doctors and the specialists, because if they are going to prescribe those specialized medicines, you need also the doctors. But we know the nurses are really the first ones on call. We need in advocacy to also look at the other resources which we require. The medicines, the therapies are not cheap. We could also encourage people when they are writing their wills to bequest money towards palliative care. Maybe those who have benefited would know what it means. And maybe in the long term, making palliative care affordable would be through health insurance. And we need to advocate for health insurance so that then palliative care can be affordable. I also wish to inform those who are listening in that at Mulago National Referral Hospital, we do give geriatric care. We have a specialist geriatrician who runs a clinic every Thursday in the medical outpatient. But of course, for those on the wards, she also responds to consultations. But we need more. Of course, as a hospital having one, we need to encourage more. And I would encourage that even all other hospitals which are secondary, tertiary care should have specialists in geriatrics. We need to encourage more people. Then we need to really engage our communities to understand what palliative care is all about. And that will help us to make them part of the care that we give to those less unfortunate that are at end of life and have this suffering. The love they get from the community and acceptance will go a long way to alleviate the pain. We may use our medicines to alleviate pain, but the social support is very, very important. And that will help us to decongest the hospitals. I've already told you that when these people are sick, if you do not counsel them well so that they know what to do and make the patient comfortable, even at home, then the hospitals will be congested. So we need to have a deliberate effort to educate the communities so that they can be part of this palliative care, and we as healthcare institutions will reduce on the congestion of such cases. Once again, thank you very much. It's been a pleasure to be part of the panel and to be part of the institutions which support and advocate for palliative care. Thank you.
Thank you so much, and for being around and for staying up to the end of this webinar. I have only 3 announcements to make, and then it will be exactly our time to close. One is that this webinar was part of the events that we set aside working with the Ministry of Health to commemorate the World Hospice and Palliative Care Day. The other event hosted by the Ministry of Health is tomorrow at the Ndere Cultural Center. It is an invite-only event, so people who are going to come have invitations, and that's in the evening, and the Right Honorable Dr. Lugunda will be there as chief guest. The next event is open for all of you to come at Hospice Africa Uganda in Makindye. You please come at 2 p.m. There will be choirs for Voices for Hospices, and then there will be brief speeches and information for you to take back home on palliative care. So we look forward to having you on Saturday, the 12th of October at Hospice Africa Uganda. We also know that our friends in Ginger have organized their cervical cancer run, and we pray and ask you to please join them as they organize and as they look forward to that. The people in the ICT team were supposed to share the flyers, but that can be shared with you on all your emails because we have them. Lastly, our friends and member organization, the Kawempe Home Care, is running a fundraiser for their children's hostel that supports the work of children who get treatment at Uganda Cancer Institute. I have seen the executive director post in the chat, and still we hope and ask that you can support them. I want to thank our panelists, Dr. Byanyima from Mulago National Referral Hospital, Dr. Henry Dungu from UCI, representing Dr. Rem, and Dr. Andrew Sechtoreko for being so kind to give us your time. We appreciate all your busy schedules, but you are here with us today. We thank you all who have been online. Thank you so much, Olivia Nachigozi, for the sign language, and the rest of the deaf community who always appreciate the service that you offer. And to all our champions, the palliative care people, we saw you online. Thank you, and for being up to this moment. I want to thank you on behalf of PICAO and wish you all the rest of the good weekend. Thank you all. Thank you so much.